Hello everyone, my name is Christiana Scott. I am working on my BSN through Davis and Elkins College, and we had a project that we had to complete at our workplace. So I'm going to be taking a couple minutes to explain where I work, what I do, the project that I chose, some details about this project and why I chose it. Um, so I work in long-term care at a facility called ERCC. Um, we are a unique geriatric facility because we have a skilled unit. Skilled nursing units are rehab units, and um, we have patients that come from a lot of different locations that come for rehabilitation. We have in-home or in-house PT and OT and speech therapy services that work with these patients for an extended period of time to get them back on their feet or close to the level of functioning that they had before whatever had occurred to them before they came to us. Some examples of residents and things that we get on the skilled nursing unit are usually people that have knee replacements, hip repairs, come in for strengthening after an illness, people that recover after surgeries, wound care, things like that. So the majority of these people do have capacity and are pretty well off and independent, but just need a little extra help. The project that I chose was to concentrate on reducing pressure ulcers. A lot of people think pressure ulcers would occur more to somebody that is not mobile or doesn't have capacity, but it occurs a lot too when people like I just previously said on my unit that do have capacity and are pretty well mobile. And I think the reasons why we have more pressure ulcers on our unit is because a lot of these residents come from a lot of different locations. We'll get residents from home, we'll get residents from different nursing facilities, we get residents from a lot of hospitals, and most of the time whenever they come from hospitals, they've been there for maybe like a month or two trying to recover from some major surgery they had before they come to us, and they get pressure ulcers from there. So the majority of the time they come in with pressure ulcers. So the big problem that I saw in my facility was with the staff identifying pressure ulcers before they got bad, staging them, treating them, and then helping the resident prevent them whenever they go home. So I'd recognize this as a problem, so I developed a questionnaire that I was going to do 10 questions for the staff, and the questions revolved around the system that we use to assess pressure ulcers, their knowledge of that, how well they understood that system, what could be improved, what they recognized as high risk or risk factors for high risk patients, things that we were doing in interventions for prevention, things like that, or things that we could improve upon. And then there was a 10-question questionnaire for the residents that included if they knew what pressure ulcers were, what caused them, how they can help prevent them, if they were at a higher risk for them, and things like that. So the plan was to do this 10-question questionnaire for each. We did have to have an informed consent signed. So an email was sent to the staff giving a general idea of why we were looking at this, what we were looking at specifically, and what the proposed outcome of this would be. And they could either accept or decline. And if they chose to participate, then all they had to do was write or answer this questionnaire to the best of their knowledge and turn it in. And then that was it. And same for the residents. If they had capacity, of course, they could choose that on their own. And then if not, we had to go through the medical power of attorney. And they answered the questions, and that was all. And then, since this was considered a qualitative study, for questionnaires it wasn't 100% reliable, so I thought it would be best to later review that information, ask the same questions about 2 weeks later to the same people, and then compare those answers and see how similar they were, which turned out pretty well. So basically, it was pretty productive. And I think the biggest issue that we had was just staff recognizing the start of a pressure ulcer and what treatment plans could be put in place to treat them and make sure that they don't occur again. Is there any questions?
So recognition, I guess, is what you're saying is the biggest problem. So
Sure.
Being in a long-term care facility or rehab facility, I'm sure you guys rely a lot on your like CNAs or PCAs, whatever you call them, your aides.
Right.
So was there knowledge of those pressure ulcers? I mean, were they the ones who didn't seem to know, or was it nursing staff, or was it a mix? I mean, like,
kind of a mix. Our CNAs, like, of course, they take the CNA class. I don't know the extent of how much they touch on pressure ulcers. I know in our couple of our continuing education monthly classes and stuff, they've touched on different places and stuff that you can get pressure ulcers, like even on the back of your ears and things like that. So I think they're more aware than what people would think they are. And then the nurses are required, we do weekly skin assessments, and we have to enter that into the computer and things like that. And it's helpful too, because we just updated our system to where we could take pictures of like any wounds and stuff to compare them weekly. But the biggest problem, like with recognition, I think it is a mix of both, because I think sometimes the CNAs don't know at what point, like, for stage 1, they don't recognize that that's the start of something. So then it just goes missed. And then if that patient is competent and doesn't feel comfortable with somebody, going to the bathroom, or the nurse doesn't see it for a while, or they don't have any issues for it to be assessed, then it gets missed.
And in the future, what do you feel to reduce that? Because we all know pressure ulcers can be detrimental, even to a healthy person. Nasty infection, things like that. So what would be ideal? What do you think would change to reduce the pressure ulcer rate in your facility?
I think if we had like standardized protocols to do, which we are actually in the works of that, but it's not just with pressure ulcers, it's more towards other wound issues, but I think we need to have more of a specific standardized protocol towards pressure ulcers, and just some more education on like what they look like, because it's we don't have a lot of people that have like anything past the stage 3, but it's hard to know what the first thing you need to do is. Like, do you need to put a patch on it? Do you need to put like what is, and a lot of times too, I think it's difficult because it needs to be one thing that works for one person doesn't work for the other person. We've got a lot of mix of people on that unit, because some people are, very mobile, some are kind of, and then some not so much. So what might work for the very mobile person may not work for the immobile person. So I think if we had more of a, set of, this is what you do for this, then that would erase a lot of confusion and treatments that aren't even beneficial from being done.
I think that's all I have.
All right, well, thank you everybody for your time.